Everyone. Today's webinar topic is cerebral venous thrombosis. Presenter myself, M. Shivakumar, and moderator, Dr. Sayooja Sachidanandan. The scheme of presentation will be anatomy of cerebral venous system, predisposing factors and pathophysiology, clinical features, diagnosis, management and complications, and CVT in special situations like pregnancy, children, and infections. Coming to normal venous anatomy, intracranial venous system comprises of dural venous sinuses and cerebral veins. In these dural venous sinuses are in between this outer dural and inner dural layer, like periosteal meningeal and dural meningeal layers. They are fenestrated and they are lined by endothelium. These sinuses have internal projections. These are the internal projections called arachnoid granulations. These arachnoid granulations These arachnoid granulations connect with this subarachnoid space, help in draining the CSF into the venous sinuses. Cerebral veins, other than sinuses, are superficial or external cortical veins and deep cerebral veins. Here we can see this is a falx cerebri holding the superior sagittal sinus and inferior sagittal sinus, and these are the deep veins. These are the internal cerebral vein, and this one is a basal vein of Rosenthal, draining into the forming the vein of Galen, which is draining into the sage sinus. Here we can see the cavernous sinus and its connection with the ophthalmic veins in the anteriorly and posteriorly. It is connected to transverse and IJV through superior and inferior petrosal sinuses. This is the same image depicting the internal deep veins, and so cavernous sinus is attached to the transverse sinus by superior petrosal sinus and to IJV by inferior petrosal sinus. Superficial cortical veins. These veins run on the surface of the cortex, and they mainly this is a superior anastomotic vein, also known as the vein of Trolad, which runs around the central sulcus and connects the superior sagittal sinus to the middle cerebral vein. This is the superficial middle cerebral vein, also known as Sylvian vein, runs in the Sylvian fissure, and this vein drains into the petrosal sinus, and this connects between the superior anastomic vein and the sinus. And this is the vein of Labe, also known as inferior anastomotic vein, which connects this these other cortical veins to transverse sinus. Any of the two veins can be dominant in any person. Deep veins already we have discussed. These are internal cerebral veins, basal vein of Rosenthal and vein of Galen. This will drain into the straight sinus. This is a dural venous sinuses drainage, where superior sagittal sinus runs posteriorly and joins the confluence of sinus. And inferior sagittal sinus drains into the straight sinus, which thereby meets the confluence of sinuses, which drains into transverse sinuses. Transverse sinus drains into sigmoid sinus, which opens into IJV. Cavernous sinus, which is communicating with transverse sinus through superior petrosal sinus and to IJV through inferior petrosal sinus. This is an MR venogram image of a normal dural venous sinuses and the deep veins. Here we can see the superior sagittal sinus draining into the meeting the confluence of sinuses, and this is the transverse sinus, and this sigmoid sinus opening into the internal jugular vein. And we can see the deep veins, internal cerebral vein opening into the vein of Galen, which is draining into the straight sinus. You can see the vein of Labe, which is draining into the transverse sinus. This is the vein of Trolad, superior anastomotic vein, draining into the connecting the superior sagittal sinus with the other the sylvian vein. This is a DSI image of the normal dural venous sinuses. Here we can see the superior sagittal sinus, confluence of sinus, transverse sinus. This is sigmoid opening into the IJV. Cavernous sinus connecting to transverse sinus via the superior petrosal sinus and to IJV via inferior petrosal sinus. This is the middle cerebral vein opening into the spinoparietal sinus, which is draining into the cavernous sinus. This is vein of Labe, and this is the vein of Troland. These are superficial cortical veins. The deep veins we can see in a zoomed picture. This is internal cerebral vein, basal vein of Rosenthal, this one, and vein of Galen draining into the straight sinus. Epidemiology. CVT predominantly affects the seen in less than 55 years of age, and two-thirds occurring in women. Recent times, the incidence is increasing. The incidence before 2010 was around 5%, 5 per 10,000. And after 2010, it is around 10 per 10,000 people. Mean age at presentation also increased. Before 2005, it was 24, around 24 years. But after 2005, the average age, mean age at presentation is 33 years. Coming to risk factors and the associated conditions. Risk factors can be divided into transient and chronic. Transient risk factors are like usage of oral contraceptives, pregnancy and hormone replacement therapy in females, and also head and neck infections. Uh, Here we can see oral contraceptive usage, pregnancy and hormone. These are the these are the major causes of CVT in females. That's why it is more common in females, where oral contraceptives, it is around 50 to 70% of the cases are due to usage of combined oral contraceptive pills. And also pregnancy is one of the major cause. And the other causes causing CVT are head and neck infections, dehydration, anemia, sepsis, respiratory infection, and COVID-19 and its vaccination. Drugs like corticosteroids, asparaginase, thalidomide, tamoxifen associated with increased risk of CVT. Head trauma, post-trauma head trauma can cause CVT, and neurosurgical procedures and iatrogenic causes like jugular vein catheterization is associated with CVT, and these are the transient causes. Chronic causes, if hormone replacement therapy is for long duration, and obesity is very much significantly associated with CVT, and anemia, and other systemic diseases like thyroid disorders, nephrotic syndrome, inflammatory bowel disease is associated with CVT. Malignancies, mainly myeloproliferative disorders and other malignancies. Antiphospholipid antibody syndrome is strongly associated with CVT. Other connective tissue disorders like SLE, Behcet, and sarcoidosis. And thrombophilias, which are acquired or genetic. So here the genetic mutation in prothrombin 2021A, 210A, and factor V lead-in mutation, and methylene tetrahydrofolate reductase polymorphism, and protein C proteinase deficiency, JAK2 mutations, antithrombin deficiencies. And any compressive lesions on the venous sinuses like meningioma can also predispose to CVT. Patients with is due to vaccination mechanism and how the inflammatory anemia is due to increased viscosity, blood viscosity, and chronic hypoxia, sir. And COVID-19 vaccination, mainly adenoviral vaccines were associated with this. Covishield. Yes, sir. Adenovirus-based vaccine, but not with mRNA vaccines. It is anti-platelet factor 4 is
It's not correct. And what about inflammatory bowel
inflammatory bowel
disease?
disease is due to hypercoagulability, inflammation, sir. Generalized, they are associated with generalized inflammation.
There is one more important prediction. Protein loss from the GA. The protective proteins are lost first. Protein C, protein is everything leak out to intestine. So that will be more proton. Any email clarify you need?
Okay, sir. This is the pathophysiology of cerebral venous thrombosis, where if thrombosis of cerebral veins causes increased venular and capillary pressure, and if venous sinus are thrombosed, mainly compromises the CSF absorption, which can lead to increased intracranial pressure and thereby cytotoxic and vasogenic edema due to disruption of blood-brain barrier. And also, if it's very severe, it can cause parenchymal hemorrhage and leading to hemorrhagic infarction. Cerebral venous sinus thrombosis can be due to venous sinus thrombosis or venous thrombosis or both. Usually CVT patient presents with the gradual onset of symptoms, mainly due to slow growth of thrombus and collateralization. This causes the gradual onset of symptoms when compared to this arterial ischemic strokes or hemorrhagic strokes. Based on the onset, there's 3 types of presentations. Acute presentations within 48 hours, subacute 48 to 30 days, chronic more than 1 month. Most common onset is subacute onset. And median delay from the onset of symptoms to hospital admission was around 4 days in this CVT patients. And for diagnosis from the onset of symptoms, it's 7 days. 4 main types of clinical presentations. CVT patient can present with isolated intracranial hypertension, focal syndromes, subacute encephalopathy, cavernous sinus syndrome. Headache is the most common but least specific symptoms can be seen in 90% of the patients. Means around 10% of the patients can present without headache, and only manifestation in about 25 patients. Patients present with severe head pain, which can be worsened by Valsalva maneuvers and with recumbency. This headache can be gradual over days or sudden thunderclap headache, and site of headache has poor localization with that of occluded sinus or any parenchymal lesion. When to suspect a CVT in a patient with headache? When there are risk factors, as we discussed, like OCP history of OCP, pregnancy, puerperium, malignancy, and anemia, and new onset headache in already with different features in a known case of already primary headache patient, and also symptoms and signs of raised intracranial pressure, and if patient has a new focal neurological signs, and if the patient have altered consciousness or seizures, then CVT should be suspected in a patient with headache. Due to cerebral thrombosis, mainly drainage of CSF dural stretching, sir.
So, any of the 3 can happen.
Yes.
Or
Headache mechanism in the CVT patients due to dural or meningeal or raised ICP. This isolated intracranial hypertension is due to impaired venous return, mainly seen in isolated lateral sinus or superior sagittal sinus thrombosis, more frequently in patients with chronic presentation than the acute presentation. And other presentations, focal syndrome, where it is due to ischemia, infarction, or hemorrhage, presents with focal deficits or partial seizures, can have monoparesis or hemiparesis, sometimes bilateral. This is the most frequent focal deficit. Aphasia, patient can present with aphasia, mainly fluent type, follow the sinus thrombosis, especially if it is left-sided and lateral sinus thrombosis. Sensory deficits and visual defects are less common. Cerebral venous thrombosis clinical manifestation, if we see according to the occlusion site, For the transverse sinus, if it is isolated and there is no infarction, patient can be asymptomatic or have headache. As any other sinus thrombus can present seizures. In transverse sinus, patient can present contralateral pyramidal symptoms and signs. If left transverse sinus with having infarction, and also if vein of labia occlusion was there, patient can have aphasia. If the thrombus extends into the other contiguous sinuses, can present with focal cerebral signs and lower cranial nerve palsies. If transverse sinus, the thrombus extends into the cerebellar veins, the patient can present with headache, vomiting, limb or gait ataxia. In superior sagittal sinus thrombosis, patient can present with isolated intracranial hypertension, focal symptoms due to venous infarction like blurred vision, headache, nausea and vomiting, cranial nerve palsies, aphasia, hemisensory loss and hemiparesis, and seizures. And also, patient rarely can present with isolated psychiatric symptoms. In sigmoid sinus thrombosis, yes, ma'am. Yes, ma'am. I'm explaining to differentiate from IIH. Sigmoid sinus thrombosis, patient presents in the pain in the mastoid region, and also the different combinations of sixth, seventh, and eighth cranial nerve palsies. And if deep venous thrombosis, can be mental status disturbances, reduced arousal mainly due to involvement of thalamus and other structures, deeper structures, and patient can be present with diffuse encephalopathy or coma, can have a motor, even deep can present with motor deficits.
So this is not a asymmetrically, but so it can combine. So that percentage to the total applies ongoing for it once.
The deep venous system can present with unilateral, later becoming bilateral, and also can present with fluctuating alternating paresis. Cortical veins, these according to the site of occlusion, they can be focal neurological symptoms and signs, and also as they are superficial thrombosis, more likely to cause seizures. And cavernous sinus thrombosis presents with headache, ocular pain, chemosis, proptosis, ocular nerve palsies of third nerve, fourth, sixth, and ophthalmic division of trigeminal. If the cavernous sinus is caused due to infection, patient can have fever. Other presentation, as we discussed, is subacute encephalopathy, mainly in elderly patients with a depressed level of consciousness, and seen main in deep venous system thrombosis. Cavernous sinus, we already discussed. Deep venous CVT. It is due to deep veins, internal cerebral vein, basal venous of vein of Galen straight sinus. This causes compromised drainage of the deeper structure, mainly diencephalon structures, leading to thalamic infarctions, bilateral thalamic infarctions. Here we can see the T2 image showing hyperintense in the bilateral thalamic areas. And also this is the Zeblio image showing hemorrhages inside that infarct. Here we can see the hypointense signal in SWI, where the thrombus of this is vein of Galen and the straight sinus. This is a plain CT image showing the hypodense infarct, hypodense in the bilateral thalamic region. And this is a CT venogram where we can see the non-visualization of this internal cerebral veins and also the vein of Galen. Unusual presentations of CVT, they can present with isolated headache or severe sudden thunderclap headache, transient ischemic attacks, attacks of migraine with aura, isolated psychiatric disturbances, tinnitus, isolated or multiple cranial cranial nerve involvement, and subarachnoid hemorrhage. With the principles of diagnosis with neuroimaging are should have neuroimaging helps in direct visualization of thrombus and absence of venous filling, and the consequences of this obstruction at tissue level and vascular level, where at tissue level, you can see venous infarction, edema, hemorrhagic transformation, intracranial hypertension, and hydrocephalus. At vascular level, we can see dilated veins, mainly dilated veins due to the obstruction of the other thrombosed veins. This is mainly due to collateral formation and engorged dilated veins and collaterals. CT brain, non-contrast CT scan can show dense vessel sign and cord sign, where this is due to increase hyperattenuation due to increase of hemoglobin and red blood cells within the thrombus. Here we can see the hyperdense vessel sign in the CT scan, and all this is a transverse sinus thrombosed. This is called also known as a cord sign.
The first image you can see a straight sinus and the straight circulation.
Yes. Yes, sir. Yes. Straight sinus. Here we can see the straight sinus and the vein of Galen also hyperdense. Yes.
So hyperdense cells are usually seen in dehydrated patients, low concentration, or thrombosis, or maybe as micro strokes, you can see problems in their arteries. But dehydration and low concentration more diffusely everywhere you will see that, and there are arteries and entire venous system you can see like anything focal out of proportion, the rest will tell that there is a problem.
These changes can be seen from up to 14 days from the onset of symptoms. Then, yeah, CT brain we can see identify the ischemia and also hemorrhagic transformation, and you can see the hemorrhagic transformation in the infarcted area and with the mass effect. And also here this is a here we can see a small hyperdense area, semicircular area, where in the CT scan, plain CT scan, this is known as cashew nut sign. It is mainly a C-shaped hyperintensity, which is highly specific for CVT but has low sensitivity. This is due to thrombus of the arcade segments of the subcortical veins, which run parallel to the subcortical view fibers. That's why they are C-shaped, and this is very specific, but with poor sensitivity. CT venography helps in identify the thrombosed veins due to by identifying the absence of flow in the scans, where we can see partial circumferential enhancement of the thrombosed venous sinuses causing the empty delta sign, leading to this is due to non-filling of the contrast, and peripherally the contrast can be seen enhancing. In between the center is the thrombus. This is seen, this empty delta sign is seen in contrast CT scan. Sensitivity is around 95% and specificity is around 91%. False positives are mainly due to normal sinus hypoplasia and arachnoid granulations. Here we can see the contrast filling in the normal contrast filling in the superior sagittal sinus, but here in the transverse sinus there is no filling. This is due to thrombus.
In venous infarct, you use a lot of tissue edema.
Mainly because of mainly compromise of the drainage.
Yeah, it's an obstruction. So there's a back pressure there. That's the reason for it having very severe edema as well as injuries.
MRI in CVT, useful in detecting cortical venous thrombosis, which can be missed in CT scan. Conventional series like T1, T2, flare and venogram detect thrombus, and sensitivity is 82, specificity is 92%. In acute form, in any acute thrombus, there is a high amount of deoxyhemoglobin, and in subacute forms, there is high concentration of methemoglobin. In acute, T1 and T1 shows, which is within 1 to 5 days. T1 is a iso-intense and T2 is hypo-intense. And in subacute, T1 hyperintense, T2 hyperintense. While coming to chronic infarcts, chronic thrombus, it is iso-intense and both isointense in T1 and T2 can be hyperintense also in T2. MRI is best technique to assess this parenchymal involvement to identify ischemias, hemorrhages, and edema. Um Clot appearance, as we discussed, depends on the age and helps in aging the thrombus. And GRE sequence, gradient echo sequence, and SWA mainly used in this because this thrombus is hypointense in this sequence. You very much useful in detection of acute CVTs. In SWI, isolated cortical vein involvement uh, with a high sensitivity, we can identify this cortical vein thrombosis. Here we can see the T2 image showing flare, showing the bilateral thalamic infarcts, and this is SWA sequence uh, showing the hypointensity in the straight sinus, vein of Galen, and also internal cerebral veins. Here we can see heterogeneous hyperintensity with edema, surrounding edema, and also some mild mass effect. Here bilateral, uh, you can see bilateral infarct, frontal area with edema and mass effect seen in sagittal sinus thrombosis. Here we can see the non contrast is not filling in this hypointense area in this MRI, and also this is a phase contrast MRI showing non visualization of the superior sagittal sinus and also the some deep veins. MRI
They're not exactly
artery is
not also proportionate and hemorrhage because it is strongly about CV.
if the infarct is not following the any arterial territory and if there is a hemorrhage in the infarct, we should suspect CVT.
There are going to be an arterial distribution, so you can think of it like that. But out of proportion, very literally, yes. You go for SWA, maybe you could be only
MRI with MRV is mainly used.
they use that the MRI is especially beneficial to helping detect cortical weight from it's a tissue.
You don't have that picture, sir. Cortical vein thrombosis.
Isolate cortical vein thrombosis when you take SWA, one single thrombus vein is standard. That should be helping you identify cortical vein thrombosis. Otherwise, it may not be visualized in MRI or the play CT. Only the SWA is not high. Show you that.
In MRV, an MRI with MRV, the abnormal signal in sinus and corresponding absence of flow on MRI establishes the diagnosis of CVT. In TOF, the absence of flow in thrombus sinus uh, can be detected without the need of contrast medium. But the high risk of false positive due to non-dominant hypoplastic transverse sinus. Here we can see uh, the thrombosed superior sagittal sinus in the T1 weighted MRI. And here where the MRV, where we can see non-visualization of the complete superior sagittal sinus and some of the cortical veins. Here, this is MRI, few MRI sequences where we can see bilateral thalamic infarct and the hemorrhages into the infarct in bilateral thalami in the SWA sequence. And this is a straight sinus and vein of Galen infarct showing in the thrombus in the plain CT. And this is the SWA sequence showing the a low intensity signal denotes the thrombus in the straight sinus and the vein of Galen.
The positive part of the circle, grades are moving and the straight. All the
This is a This is regarding one sign, breast sign in CVT. This can be seen. This is also seen in SWI sequences, where we can see the abnormal hypointensity in subependymal and deeper medullary veins and subependymal veins, which runs parallel to this. These veins usually normally drains the white matter, and due to this thrombus, there can be due to hypointensity uh, in this leading to appearance of a brush. And here in the same patient, we can see the thrombus in the straight sinus vein of Galen. This is due to, sir, but it is described as brush, sir. Seems like tigroid appearance also. This breast sign is associated as a mark, is marker of severity in the thrombosis of cerebral veins and sinuses seen in severe thrombosis. DSA, role of DSA in CVT is mainly to confirm the diagnosis when there is CTV or MRV is inconclusive, and when you suspect DAVF in patients of CVT, and isolated thrombosis of cortical veins. These are usually seen in very much well picked in SWI, but better than SWI, we can pick in this DSA. We can see dilated or tortuous veins, corkscrew veins. Mainly, this is due to formation of collaterals and also dilatation, increased pressure. Okay. SWI.
Please stay back on that picture because we have got
Yes, sir.
there is something called a rerouting. Suppose there are positive part of the superior cycle sinus composed.
Yes, sir.
How the veins can drain or
Yes, sir.
this
Here we can see DSA, the filling. There's no non-visualization of superior.
When there is a focal thrombosis happening, there are pathways which we can potentially reroute the venous outflow. So here, in the superior cycle sinus, for example, if it is the posterior part of the superior cycle sinus, what would be the pathway for rerouting?
Here we can see if mainly the posterior sagittal sinus thrombus, we can see the engorged or dilated frontal cortical venous channels. Mainly this is a trolad, vein of trolad, and it is draining in opening.
Vein of trolad has to go to the transverse sinus.
So trolad can, this is trolad and this is a medullary, and this is a...
They are enlarged cortical veins, which you can think about as Sylvian fissure in the lateral. So the superficial and deep middle vein venous system are located superficially and deep into the Sylvian fissure. So the all cortical veins, instead of going to the superior cycle sinus, they will drive towards the Sylvian fissure to join the deep and superficial middle cerebral venous system.
Middle cerebral, then
superficial middle venous system, which can drain into the sinuses which are present in the skull base.
Yes.
Okay. So mainly the cavernous sinus. You can show the cavernous sinus. From the cavernous sinus, there are multiple channels which can potentially connect to the transverse sinus and sigmoid sinus and anteriorly to the orbital veins. Superior orbital vein can connect to the facial vein. And also from the cavernous sinus, you go to the down to the venous plexus, which is in the skull base in the prepondine
clival plexus.
It can come down and it can go to the vertebral venous plexus and it can drain out to the Sayooja venous system. So the outflow tracts from the cavernous sinus are free. So it's a very, very protective mechanism when there is a focal thrombosis happening somewhere in the venous system. There are other potential channels which can drain away the veins. This is a very important thing. So when there is cycle sinus getting more rerouting of the cortical veins in the superficial and middle deep venous system, draining into cavernous sinus, which has got multiple outflow tracts. For example, the petrosal veins, superior petrosal through the orbital veins, and then to the pterygoid plexus, and also it can come down to the vertebral venous plexus. So outflow tract of cavernous sinus you should be very, very sure of. That is a very important mechanism by which the brain is started. Understood.
If you see the superior sagittal sinus thrombus, the blood is rerouted or due to other via other channels draining into the, here we can see in the superficial middle cerebral veins, that is draining into the superficial spinoparietal sinus, and that is draining into the cavernous sinus, and thereby draining into the transverse and this IJV. And also anteriorly, we can see it is draining into the ophthalmic veins. From there,
Some amount down the vertebral veins.
CVT and dural AV fistula. This patients with CVT can 2.4% of the patients it's seen in different case series, and averagely around 2.4 patients can have developed DAVF. This is due to opening of arteriovenous pathways causing to the dural in the dura, causing atrial and venous fistulas. Mostly DAVF can be diagnosed simultaneously at the time of CVT diagnosis, and also maybe after few days or weeks subsequent to the CVT. Patients are older, usually males, and chronic CVT has high risk associated with dural AV fistula, and mainly with sigmoid and transverse sinus thrombosis, and but less frequently associated with parenchymal lesions at baseline imaging compared to CVT patients without DAVF. This dural AV fistulas mainly has preference towards to left side. These should be detected in the patients, and early treatment is needed with embolization or surgery or radiation therapy. Actually, this DAVF patients presents with almost similar symptoms like headache, tinnitus, and if a patient complains of such things, we have to suspect dural AV fistula.
Like chronic raised ICT.
It's chronic raised ICT channels open.
Why what the result for a dural AV fistula?
Mainly due to built up pressure already.
Chronic happens.
Angiogenesis. So angiogenesis.
Why in cerebral thrombosis a lot of dural AV fistula happen?
Like multiple factors like angiogenesis and also the drainage, sir, because the main outflow drainage is venous pressure is high, sir. So there will be formation along with this angiogenesis. CVT
Would have a raised ICT symptom or a visual symptom or a low symptom, persisting or developing after CVT, which is strongly think about the development of dural AV
CVT can occur during the development of, even with DAVF. DAVF also can lead to CVT, and in CVT patients also can have a dural AV fistula as a complication. Mainly in dural AV fistula patients, due to this high flow from the arterial to venous circulation, it damages the endothelium, thereby triggering the thrombus.
So the high pressure arteries are getting connected to the low pressure venous system, but the endothelium is not understand for the high pressure. So that injury to the endothelium.
Here, this is one of the one patient example. Here we can see the bilateral transverse sinus thrombosis. In the same patient was presented after 6 months with increased severity of headache, where we can see persisting bilateral transverse venous sinus thrombosis, and also developed hemorrhage in the temporal lobes. Hemorrhage in temporal lobe, and also venous aneurysm. This one, sir. The same patient, DSA has been done at the 6 months after the initial presentation, where we can see the venous phase during the arterial phase itself. The transverse sinus is getting filled. via the meningeal and occipital arteries. After the embolization, after the treatment, we can see that filling has been here. We can
Actually, the injection into the external carotid,
yes.
in which you can see the terminal branch of the external carotid. The superficial temporal, you can see the maxillary. You can see an enlarged engorged internal maxillary artery, and also some fistulation happening at multiple levels. So a medical system and to the node branch as well as the phenotype.
But after treatment, you can see this is an arterial phase, not filling the transverse sinus as we have seen in the previous images. That has been treated with embolization.
The artery, can you show that superficial artery and the internal maxillary came over the first?
Superficial meningeal, sir. Maxillary.
This is the internal maxillary artery, which is an important function.
Here this. Other laboratory investigations, basic routines and ESR, PT, APTT, D-dimer, CSF if infection is suspected, and thrombophiliac investigations, biochemical and genetic causes of
Both
thrombophilia.
of multiple etiology and anemia of multiple etiology and lymphoma. Very fever will be kind of SP and maybe that questions are still for the same.
Heparin-induced thrombocytopenia and vaccine-induced thrombocytopenia.
Protein C, protein F, and homocysteine levels when a patient is coming with the acute CVT.
No, sir. Not in acute. After further evaluation only we'll do. Because consumption of the coagulating factors that can be false.
So it can be spuriously low.
Yes.
When the active thrombocytic somewhere in the body, protein C and protein C. Consume. Spuriously show low valency. Similarly, homocysteine will have higher.
In heparin-induced thrombocytopenia and vaccine-induced thrombocytopenia, thrombosis leading to CVT, if this is suspected, should do anti-PF platelet factor 4 antibodies, because these antibodies were identified in these patients, mainly this adenovirus based COVID vaccines. Yes. Principles of management, mainly CVT treatment should begin as soon as the diagnosis of CVT is confirmed, and patient needs rapid anticoagulant therapy. And after finding the underlying cause, patient needs long-term anticoagulation. Other complications like intracranial hypertension, seizures, and DAF should be addressed. Anticoagulation, these anticoagulation early anticoagulation is good because it promotes recanalization, prevents clot formation, expansion, and also recurrent VTE events in these patients. Low molecular weight heparin better than unfractionated heparin, mainly due to feasibility in dosing, predictable effect, and low risk of thrombocytopenia with low molecular weight heparin. And unfractionated heparin may use in the renal insufficiency and rapid reversal of anticoagulation is needed if we are planning any neurosurgical intervention. And
there is no significant difference in the therapeutic benefit of versus unfortunate affair. But we need to consider special situations which has to be kept in mind before deciding. If you want to closely monitor the level of anticoagulation rate in case of massive venous infarct with hemorrhage already there, better option will be unfractionated because we can titrate, we can monitor the level of anticoagulation. And in case if you want to bring it down or modify, either low or we can do that. But the longer term, if after you have given it, then you cannot monitor the value effect.
If a patient with CVT has hemorrhagic transformation or ICH, isolated SAH, these are not contraindications for anticoagulant treatment. If these are due to CVT, and degree of venous recanalization and duration of anticoagulation remains the area of uncertainty. Preventing further venous thrombotic events needs long-term anticoagulation, and also risk of recurrent CVTs was around 2 to 7% per year. and the risk of other venous thrombosis in patients with CVT around 4 to 7% per year. To prevent this, they need long-term anticoagulation. Oral vitamin K antagonists are used with INR target of 2 to 3 for 3 to 12 months based on the underlying risk factors of recurrence and etiological findings. Yes, I mentioned. Yes, ma'am, I mentioned in the further slides, sir. Yes, ma'am, yes. This is duration of
You are. We are coming to that.
yes, I'm correct. If a patient is having one episode of cortical venous thrombosis and any transient risk factors are associated, and this transient risk factor due to the means if this patient is less likely to have a recurrent event, so the anticoagulation therapy can be for 3 to 6 months. And if CVT is identified one episode and unknown cause, the anticoagulation can be considered for 6 to 12 months. And if they have a recurrent more than 2 or more than and having a identified prothrombic condition and with a high thrombotic risk, patient needs lifelong anticoagulation. If a patient has having a CVT and along with he's having other thrombosis, other areas like deep vein thrombosis, then he's likely to have high this high risk. So he needs a lifelong anticoagulant therapy. Few trials related to this anticoagulation. Respect CVT trial where it is compared with dabigatran and warfarin, where dabigatran and warfarin either had low risk of recurrent venous thromboembolism and risk of bleeding was similar, suggesting that both dabigatran and warfarin are safe and effective in preventing recurrent VTEs in patients with CVT. Secret trial compared with comparing the rivaroxaban and the standard care with warfarin. It showed in this patients were like pregnancy and antiphospholipid syndrome patients were exempted. Here, safety and in both arms. Here also we can see functional and the high rates of reduced quality of life, which was there prior to the starting of the study, as there was a marked improvement in even in the rivaroxaban arm. Action CVT trial compared vitamin K antagonists and also other oral anticoagulants directly acting apixaban, rivaroxaban, dabigatran, and also patients on multiple oral anticoagulants. Here, there was no significant difference in the rates of recurrence of venous thromboembolism, clinical and radiographic outcomes, and favorable safety profile. And there is reduced risk of major hemorrhage in directly acting oral anticoagulants. Here is a snapshot of this study where lower hemorrhage risk with DOACs and also similar death rate, recanalization rates, and recurrent venous thromboembolism risk were comparable in both arms. This is a study EXCOA CVT trial extending oral anticoagulant treatment for cerebral vein and dural sinus thrombosis. It's a prospective study comparing short duration and long duration anticoagulation after an episode of CVT. And it's an ongoing study. Results are yet to be published. Actually, this is the only study which is currently undergoing this to determine the duration of anticoagulation, which is till now there is no proper consensus. Treat. This study is comparing the short duration 3 to 6 months and the long-term 12 months anticoagulation therapy in the patients of CVT. New oral anticoagulants recommendations Basically, the both vitamin K antagonist and this can be used after a period of lead in parenteral anticoagulation. But whether 5 to 15 days is safer or more effective strategy than shorter periods is not known. Uh, the area of controversy is like timing of initiation with or without lead-in heparin, whether acute venous thromboembolism dosing is initially required, and optimal candidates for NOAC therapy are still area of controversy. And NOACs are not suitable in women who are pregnant and breastfeeding, and associated with high risk of recurrent venous thromboembolic events compared to warfarin in the patients with antiphospholipid syndrome. For patients with cancer, NOACs were found to be non-inferior to low molecular weight heparin in prevention of venous thromboembolisms. There is limited evidence of the role of antiplatelet agents after discontinuation of oral anticoagulation in CVT patients. Reperfusion therapy reduces the burden rapid.
The acute CVT, the many cases will have elaborated about. One entity is not to be treated with the heparin or heparin.
Sir? Sorry, sir.
One of the many conditions elaborated
Yes,
you can have a CVT. And one entity is not to be treated acutely with heparin or heparin or antiparin. But a treated in some other.
Antiphospholipid.
No, no. If the COVID vaccine
That is, yes, sir. That is IVIG and steroids are also advised, sir. And reperfusion therapy reduces thrombus burden rapidly. Uses this mechanical thrombectomy with or without intrasinus thrombolysis. Recanalization rates achieved were 70 to 90%, but ICH was seen in around 10% of the patients. Most effective for acute rather than well-established thrombus. Trial TOAC trial is for EVT compared with medical management. EVT with medical management versus standard care of severe cerebral venous thrombosis. Here, patients have favorable outcomes. They have reached to achieved MRS 0 or 0 to 2 at the end of 12 months, were similar in two groups. Mortality rate numerically higher in EVT groups, but it was statistically insignificant. Symptomatic hemorrhage high was higher in medical management group, suggesting EVT may be effective in reducing risk of further bleeding. Only in acute severe CVT or in acute conditions where the patient is progressing in spite of best anticoagulation therapy. Yes. Endovascular therapy, larger.
Think of a thrombectomy or think of EPE.
With endovascular therapy and with or without thrombolysis, sir. During the case, mostly it is done with thrombolysis.
Any information that during the thrombectomy, can it have a pulmonary proof?
Not sure, sir, but venous system, yes.
Thrombus can come to the right area and that's the pulmonary. More
no current evidence to determine EVT techniques in superior to the other therapeutic strategies. It is used as a rescue treatment only when clinical deterioration despite anticoagulation or failed or having contraindications to standard therapy. One study has shown that patients with midline shift less than 5 mm and GCS more than 9 has maybe a good candidates for this for the EVT procedure. Fibrinolytic therapy is used mainly if despite anticoagulation, if there's clinical deterioration, and also patient with intracranial increased elevated intracranial pressure, urokinase and alteplase are most frequently administered, and uh, intracranial hemorrhage is a common complication. It can be thrombolysis can be due to via direct catheter, or also direct along with the mechanical thrombectomy. EVT, like balloon assisted thrombectomy and thrombolysis and catheter thrombectomy. Intracranial pressure is medical management. Mainly its presence with due to the brain edema, infarction, and hemorrhage. It can lead to increased pressure and herniation. And the medical therapy with mannitol and hypertonic saline and hyperventilation are useful. And there is no evidence of carbonic anhydrase inhibitors in CVT patients, and corticosteroids not used except in underlying inflammatory conditions. Decompressive surgery is considered if there is impending herniation as a life-saving procedure, and it has shown favorable outcome in 50% of the patients with a mortality rate of 15 to 18%. Mainly patient is truncal herniation and midline shift greater than 5 mm, and herniation-induced ischemia in PCI territory. These are some of the indications for decompressive surgery. And it has a poor outcome if the patient is greater than 50 years and midline shift greater than 10 mm, and total effacement of basal systems. This is a observational study of Decompress 2, where it showed after 1 year surgery, 2/3 patients were alive, and more than 1/3 patients were independent, and 4 out of Asian and Indian same contributed maximum patients in Indian patients. Man. Of course, this in 10 countries, India is also included. This surgery was like they felt like it was worthwhile by 4 out of 5 patients and the caregivers. Results support that recommended to perform decompressive neurosurgery in patients with CVT with impending brain herniation. Monitoring of visual complications in the raised ICP mainly presents. We should watch for blood vision. Yeah. Visual symptoms, if present, are common, around 13 to 28% incidence, and baseline ophthalmological examination within 7 days of CVT and follow up at 4 weeks and 3 to 6 months. Recommended even if papilledema is not present. Sometimes because late onset papilledema is seen even after the full venous recanalization, resembling IIH. This is to differentiate a patient presenting with intracranial hypertension. We should differentiate it from idiopathic intracranial hypertension. And here we can see there is no clinical feature reliably distinguishing between two, but female gender was common in IIH, and the low CSF protein was significant, more frequent in IIH. CT missing often misses this venous CVTs. So MRI and MRV is reliable to diagnose it. So MRI and MRV is essential to rule out this CVT. And after that, only you can diagnose as IIH. It's a diagnosis of exclusion. Isolated cortical venous thrombosis. Okay. In isolated cortical venous thrombosis, this GRE gradient echo sequence is the most sensitive technique to demonstrate the presence of thrombus in the cortical vein, and also the HWI sequence. Anticoagulation, in this also, the treatment is anticoagulation.
Establishing the diagnosis is their most challenging part here. So, document the thrombus to cortical vein very important. Therapeutic surrender.
Yeah, this is algorithm in the AHA 2024 guidelines for CVT, where after the imaging, if there is no evidence of CVT, consider the other diagnosis, and CVT confirmed. If there is a mass effect and midline shift and signs of herniation, patient to be considered immediate emergency decompression hemicraniectomy. And also with if CVT without this, can patient be managed on parenteral anticoagulation with low molecular heparin and unfractionated heparin, and with clinical imaging shows stable CVT, and the transition to oral anticoagulation with uh, direct oral anticoagulants or warfarin. Duration is based on the transient risk factors or high risk thrombophilias, recurrent VTs. Such patients need indefinite oral anticoagulant. Low molecular weight heparin is preferred in pregnancy. If there is progression on imaging, thrombus propagation, we can consider EVTs and endovascular thrombectomy, endovascular therapy, and with or without intrasinus thrombolysis.
One more thing you can highlight, okay, the previous slide. For a clinically, what are the things
Yes. Actually, if CVT confirmed, for to establishing an etiology, if we can have should do clinical exposure and history of drugs like OC, otitis, infections like otitis, mastoiditis, and facial infections, which can lead to thrombosis, and dehydration, head trauma, and Behcet syndrome, sarcoidosis, and ulcerative colitis, and patients with malignancy and other rheumatological conditions, as these associated with high risk of thrombosis. Exposure to oral contraceptive pills, chemotherapy agents, COVID-19 infection or its vaccination, and these are the seizures in patients with CVT. Focal or generalized seizures, including status epilepticus, can be seen. Yes, sir. Around the seizure presentation, 30 to 50% patients, and mainly sagittal sinus and supratentorial lesions are associated with seizures. Seizures due to this edema, infection, hemorrhage, and ASMs continue at least 1 year. For if patient is have a single early symptomatic seizures in the absence of supratentorial cerebral lesions, benefit is uncertain due to low likelihood of recurrence. Seizure prophylaxis are avoided if there is focal cerebral lesions and the patient is not presented with seizures. No strong evidence for routine prophylactic anti-seizure medications. Pregnancy, high risk in third trimester and first 6 weeks of postpartum. Cesarean delivery associated with high risk, and in CVT, pregnancy in CVT, CVT patients with pregnancy, low molecular weight heparin is indicated during pregnancy and also 6 weeks of postpartum. Warfarin during pregnancy is avoided due to teratogenicity, and there is limited evidence for endovascular therapies in the pregnant patients, and thrombolysis and thrombectomy reserved for the deteriorating patients in spite of anticoagulation. Future pregnancies and recurrences.
patient is developing early, find a itch, heparin to acute CVT, the start on heparin fraction, and you find that there is a port of parental count, and more to itch. So you
It is treated by coagulation factors, and platelets are avoided.
heparin, where has led to thrombophagy and hence heparin. Heparin.
Future pregnancies and recurrence. Future CVT is not a contraindication for future pregnancies, and also this history of CVT and prophylaxis with during future pregnancies. If there is high risk of CVTs and other venous thromboembolism, oral this long-term anticoagulation is advised, and progesterone only therapies are advised.
Regarding the first slide, we have thrombosis happening pregnancy, but you find that there is a no thrombotic stage and further pregnancy advice.
We can advise further pregnancy with coverage, anticoagulation coverage.
People, kind of situation.
Pediatric CVT seen in 0.67% per 100,000 children per year. It is, but when compared to pediatric, neonates have more prevalence of CVT, mainly due to sepsis, head trauma, hypoxia, and dehydration. And there are some predisposing factors like anemia due to hemoglobinopathies, congenital heart disease, and underlying malignancies and inflammatory conditions can predispose CVT in pediatric patients. Diagnosis mainly use in units. Of MRI has high false positivity. CT venogram to confirm, and also there is role of Doppler ultrasound, and also they have more high hemorrhage transformation in units than in children. Management of kids dot trial and Einstein. Ma'am, sir. Come wise adult choice. This kids dot trial comparing this anticoagulation therapy for 6 weeks and 3 months. 6 weeks of anticoagulation was non-inferior for the recurrent venous thromboembolisms and bleeding events. Einstein junior trial compared rivaroxaban safety and efficacy of rivaroxaban, where it has shown rivaroxaban has associated with zero recurrent thrombosis and zero major bleeding compared to the standard anticoagulants. It suggests that rivaroxaban or standard anticoagulation has a favorable clinical outcome. Management of CVT associated with infection, mainly it is treated with antibiotics and surgical drainage if needed.
Here, you should be describing mainly about the cavernous sense, which are totally different recovery.
Yes.
Unlike the other bleeds.
Infections based on the different locations can cause venous thrombosis. Well, AHA and ASA guidelines, no clear recommendations for anticoagulation in infection-related CVTs, but there is no contraindication.
Cavernous sense thrombosis would vary in etiology, unlike other venous thrombosis. Infection is the most common situation. So antibiotics.
COVID vaccine, and as we already discussed, it's associated with CHAD vaccines and adenoviral vaccines, and not associated with, like, not seen in with mRNA vaccines. Okay, sir. All patients had thrombocytopenia. All patients had thrombocytopenia and tested positive for PF4 antibodies and treated with IVIG, and steroids were advised. SIH in CVT, it can be seen as a complication of 1 to 2% of the cases of SIH, and it is due to increased venous dilatation and velocity. In this epidemic, finished. This long-term sequelae, overall prognosis is favorable, and in hospital mortality is 1 to 4% and 8 to 10% during the long-term follow-up. 80 to 90% achieved functional independence. But patients in long term have cognitive deficits, mood abnormalities, headache, and seizures, often leading to unemployment. Epilepsy is mainly affects around more than 10% individuals with CVT. Risk of recurrent CVT around 2 to 7% per year, and venous thromboembolism risk in these CVT patients is around 4 to 7% per year. CVT is a rare form of stroke affecting the young age groups and mainly reproductive age females, and we should have high index of suspicion. Diagnosis CT and MR with venography is useful, and low molecular weight heparin is a mainstay of treatment. Anticoagulation is the mainstay of treatment.
So you should tell that global heparin. If you're telling that, okay, CVT you treat global heparin, you cannot tell like that. Anticoagulation, the early and prompt and adequate anticoagulation is the best thing to ensure the best possible outcome. Understand?
Anticoagulation with low molecular weight heparin or unfractionated heparin is the mainstay treatment, and intracranial hemorrhage is not a considered contraindication for this anticoagulation. Early anticoagulation associated with improved outcome and reduced morbidity, and also EVT needs further research, and new oral have equally effective with compared with vitamin K antagonists.
Or they prolong extended. Okay.
The clinical presentation of CVT is very diverse, with the most common presentation being the most non-specific one, that is the headache. So you require a very high degree of clinical suspicion to identify the proper red flags, and also in the particular setting of a particular risk factors to diagnose a CVT. And also the median delay from the onset to diagnosis CVT is 7 to 10 days, which is also different from the typical acute presentation, acute arterial stroke. And brain parenchymal imaging with the vascular imaging is essential, with MRI and MR venogram being the most useful one for diagnosing a CVT. Once you diagnose the CVT, early initiation of anticoagulation is the cornerstone of management. Initially in the parenteral anticoagulation, followed by oral anticoagulation. And nowadays, this newer oral anticoagulation have been found to be equally effective, and is also given as a long-term anticoagulation measure. And regarding the utility of endovascular treatment, there is no specific consensus reached till now. It should be a very case-to-case tailored approach in deciding for endovascular therapy, and it is mainly used as a rescue treatment for severe CVT, which is not responding in spite of optimal medical management. Thank you.
Thank you everyone for the patient listening. We are winding up the session.